Okay, we'll call the Finance and Planning Committee meeting to order today, and we'll ask the Executive Secretary to note the roll.
Yes, Commissioner Guillermo
Present.
and Commissioner Chow.
Present?
I will read the land acknowledgement.
Yes, please.
The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land, and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples.
Thank you. We'll go on to the next item, which is the approval of the minutes.
I will move approval.
Thank you. I will second it, and I believe, according to the secretary, that actually passes the item.
Yes. Yes.
Oh, public comment on this.
Yes. Public comment. Yeah, sure. There are folks on the line. If you'd like to make comment on item 2, the minutes, please press *3 to raise your hand. All right, no hands, commissioners, and we will take your motions as approval, and we can move on to item 3, which is the monthly contracts report.
Thank you.
Good afternoon, commissioners. This is Michelle Ruggles, director of the DPH Business Office. And I have 2 contracts on the contract report. You had a couple questions, which if you were able to look at the responses back, have the answer, but I'll go through these. They're both contracts with Public Health Foundation Enterprise, doing business as Haluna Health. And both of them are contract amendments. So the first one is a contract amendment for the continued management of COVID contact investigation and contact tracing, case investigation, I think, and contact tracing, CICT, and outbreak management group. And so this is simply continuing what functions were begun under COVID. This contract is a program administrator contract, so they provide program administration of subcontract management and staff recruitment, capacity building, program support, and then the coordination of these services. As in this role, they receive an administrative fee of 12.8%, and then the balance of the funding goes towards all the programming and the position costs. Do you have any questions about this contract?
Commissioner Guillermo?
None for me.
Okay, I think my only question that just came up was that if this is an extension, I'm assuming we have been satisfied with their work in the past for this.
Yes, we have been satisfied with their work in the past. We've consistently been satisfied with their work in the past. We haven't done, well, the program review of this contract would be against their fiscal administration work, and not the content of the COVID work that's happened thus far. But in terms of the support that they provided, particularly and especially during COVID, it's been, we wouldn't have been able to do what we did without their help, because they've been integral in us being able to get a lot of needs off the ground.
Okay, so no, thank you. I think that latter is sort of the important question: how well they are being accepted by the contractors they're working with, and sounds like it's been a good relationship.
Yes.
So, is there any public comment on this item?
Folks on the line, actually, Commissioner, can we wait to do public comment until both items on the contracts report are done? Usually we do it at once.
We can do that because they're related to the same contractor, and otherwise, if we had a whole series, I was just thinking that it would be reasonable to take public comment
Well, I'll ask. Folks online, if you'd like to make a comment on the first contract on the contracts report, which is Haluna Health, please raise your hand by pressing *3. No hands, commissioners.
Okay, we'll go on to the second contract, and I would agree that we will look at approval of all the contracts together. So let us have our second contract, Michelle.
Okay, so the second contract is also with PHFE doing business as Haluna Health. This is also a contract amendment extending the contract by a year for the continued management of the COVID applied research, community health epidemiology and surveillance program and the disease prevention and control public health lab. And for one of your questions, you asked what was increasing in the second year, and the increase is the lab techs that were hired in the first year of 1.75 is increased to 7 in fiscal year 21-22, or is proposed to increase. I mean, proposed in the proposed budget, that is the increase, sorry. So again, this is COVID related, which is why this is not a long-term contract. If you have questions, I know.
Okay, so this is for the epidemiology and surveillance programs. Okay.
No,
Okay.
I'm familiar with this. I don't, and we were kind of having some back and forth before. I see Daisy is on here, but I'm not sure. We had Daisy tagged for this contract questions, but I don't know, Daisy, is this something that you're familiar with?
I can certainly try to respond. Can you repeat the question?
Well, I guess the question that I had, which is a follow-up on the fact that we are adding lab techs, is this because this is a temporary situation due to COVID?
It is.
We're not looking at permanent positions.
No.
Okay. Got you there. Thank you. That answers our question, or at least mine. I guess we'll find out if there's any public comment and then any comments from Commissioner Guillermo.
Sure. Folks on the comment line, if you'd like to make comment on the contracts report, the second contract, which is another Haluna Health contract, please press *3 now to raise your hand. *3. No hands, Commissioner.
Okay, thank you. Commissioner Guillermo?
No, it seems pretty straightforward to me. Thank you.
All right, so I think a motion to accept both contracts and recommend them to the commission for our consideration is in order.
I move approval of the report
Okay.
and the extended contracts.
Right. Recommending the contract report, and I will second that, and we can move on to our next item then.
Sure, thank you. Item 4 is a request for approval of a new contract with Nuvasive Incorporated. And commissioners, the agenda you have in your packets, I misordered the presenters, so I will read out the correct presenters. Daisy Agualo will present, and I apologize for my mistake.
No problem. Thanks, Mark. My name is Daisy Aguayo, and I am the Director of Supply Chain for DPH and also serving as the Acting Director of Population Health. Today, I am presenting the Nuvasive contract. This is a new contract, and it is to purchase hardware, biologics, instruments, disposables, and other such items for surgical spine cases. The term is set for 5 years, and the targeted population are for trauma spine cases that we perform at ZSFG. This contract is specifically just for, we have multiple implant contracts, but this one specifically is just for spine, and it's very unique. The total per year cost is a little over $1 million and spend with a 5-year estimate of about $55 million and a not to exceed of 6.2 million. Sorry, let me rephrase that. It's 5.5 million and 6.2 million. for a total of 5 years. Any questions?
Is there any public comment?
Folks on the line, if you'd like to comment on item 4 on this agenda, please press *3 to raise your hand. *3. I see no hands, commissioners.
Okay, so Commissioner Guillermo.
I'm not sure if I missed it or not in the actual contract request, but do we have an estimate on the savings that we're going to experience relative to having a contract versus a invoice by invoice basis with the purchase order?
I don't have that savings with me. We did receive a savings based on academic teaching facility nationwide discounted that I could provide to you separately outside of this meeting if that would help. But we did identify cost savings opportunity when we did develop the contract.
Thank you. That would be helpful to get that subsequent to this meeting. Thank you.
And then do you want me to send that to Mark or who do you want me to send that to?
Yes.
Mark, send it to Mark. Yeah, and he'll send it up. Yeah.
Thank you, Daisy.
And so kind of in follow-up of that, and thank you for that question, it does say that this is going to be per case. So I guess the savings is that presumably versus invoice that we have a more favorable rate?
We negotiated to bring forward this contract, we negotiated better rates with NuVasive. Yes.
So it'd be good, as Commissioner Guillermo asked, to sort of get a quantification of that. From a standpoint of management in our surgical units, I actually am a little surprised that we were now doing this when it sounds like for a long time we've been using these people, and that they are a very specialized group, and that's what our surgeons are using, right?
That's correct.
Okay, so just wanted to be sure I was reading that correct. And
Yes.
so it isn't that we're allowing 5 or 6 different contractors to provide similar services.
We are for spine. I want to say there's only 2 or 3. It's so unique. There's only 2 or 3, and NuVasive is the prime vendor.
Okay, and it's sort of up to the surgeon which he's best using, because these are really specialized tools between these 2 or 3 vendors, right?
I'm sorry. The question was.
Well, the question is that each of the surgeons can, in fact, determine which one of the 2 or 3 providers.
Yeah, they base it off of the patient that's on the table. They base it off of the severity of the trauma.
Oh,
And so it could be a Stryker case or it could be a NuVasive case. It all depends on when the patient arrives,
sure.
what the physician is going to choose.
Okay.
Yeah.
All right, so I think we've already asked for potential public comment. We can go on to a motion. for approval
I
to-
will move approval of the NuVasive contract.
Okay, so a recommendation for approval to our Health Commission, I will second.
Thank you both.
Can we move on to our next contract?
Yes, item 5, the request for approval of a new contract with RL Datix, North America Incorporated, and Susan will present.
Good afternoon, Commissioners. My name is Susan Brajkovic, and I am the Director of Risk Management and the Program Manager for the Risk Department here at Zuckerberg San Francisco General. I want to introduce my team who's all here today. We have Adrian Smith, Chief Quality Officer for Zuckerberg San Francisco General. We have Troy William, who is the Chief Quality Officer for the network. We have Emma Moore, who is the Lead Risk Manager at Zuckerberg San Francisco General. And we have 2 guests on the line from the vendor side, Adam Scott and Dave Swanson. So this contract is a new contract. It is the purchase of safety software technology aimed to reduce the impact of harm and to assist our organization with quality improvement activities. This system serves to replace a homegrown system that's over 10 years old and currently is not supported by our IT department. And it comes with 3 discrete operational areas that we refer to as modules. The first module is it's called RL6, which is used to capture any incident, near misses, unsafe conditions for staff, visitors, as well as our patients, our primary group. The second one is RL6 root cause. This is the module that's used with incident reporting to do quality reviews, what we call RCAs or root cause analysis. And really it's used to track the analysis and the improved tracking functionality of the follow-up action items when there is a quality improvement activity. The third module is RL6 feedback. This is a module that is a reporting system that is designed to capture any type of complaint, compliment, or grievance, or a suggestion. And this too applies to patients, visitors, and staff. So I want to describe for you the overall features of the system and why it's important that we look at this contract. One, all modules within this technology software communicate with one another. So all 3 modules talk to one another, and the users, i.e. the San Francisco General, Laguna Honda, and primary care clinics will all be using the system such that the users can all see all 3 modules. The system is integrated within Epic. That's a feature that was lost when the organization switched to Epic, resulting in manual lookup, manual data collection, manual trend reviews. With Epic integration, the demographics of the people that are, the folks that are being reviewed, either the patient, the visitor, the staff, can be obtained with an emphasis on tracking of race, and more importantly, if there's any potentially associated racial disparities with any of the incidents that are reported. Next, the system's needed to maintain regulatory requirements. So as you know, in the quality world, there are many regulations involving incident reports, sentinel events, as well as complaints and grievances. So the system is already built with these regulated mandated fields. For example, workplace violence has the mandated fields as required by Cal-OSHA, which is the California organization that tracks workplace violence against staff. Next, the system is sophisticated with monitoring and reporting capabilities, really significant when it comes to tracking data trends. And the system will allow for not only quality management risk managers to pull the reports, but it will allow users at the unit-based level. So if it is a unit within Laguna Honda, within primary care, let's say the ER manager wants to pull a trend in their unit on particular incidents, safety events, complaints that they are receiving in their units, they'll be able to run that report. The system is electronic, requiring less manual process. Again, as I told you, we have a homegrown system. So we use a variety of Excel, pivot tables, manual word searches. So again, we are limited in functionality with using data to drive improvement. And I know the commissioners are well versed that data is the driving force to identify where the trends are. And so the data tracking functionality is paramount as we want to improve our quality improvement activities. I already shared the modules within the system are interconnected. So again, not only will be able to, the users, to be able to see all the modules, but if there is feedback in any one module, the other 2 modules will have that feedback if it pertains to the same patient, visitor, or staff. And I know with certain instances, if there's been an incident reported that then becomes an RCA, that then later on becomes a claim, it's really important to have one place to go to gather all of that information about how the case was reviewed, what our countermeasures were. Lastly, and I'll wrap it up here, the system will be supported internally by risk management team and site administrators. Right now, as I said, our IT department does not support our current system. And the system is also the system that is currently used by UC, therefore creating familiarity and utility by the UCSF providers, residents, and medical students. They've had it for a number of years now. The target population is intended for ZSFG Laguna Honda primary, with future opportunities within the network such as jail health. That is not on this current phase, but it is something down the road that we can look at. Lastly, contract deliverables are a number of things: implementation, designing and building for implementation, testing and training, go live readiness, certainly post live support, maintenance and supporting, and as needed optional professional services. Those are the highlights. I'll open it up for questions for myself, the team, or our vendors who are joining us on this presentation.
Okay, so Mark, can we ask for public comment first?
The only folks in the public comment are the vendors, so there is no public comment. But
Okay, unless they wanted to make something.
I think they'll only respond to questions that you all have. I think that's the best way to interact with them.
Okay, so we'll go on to Commissioner Guillermo.
Thank you. I had a couple of questions, and I'm sorry I didn't ask these in advance, but the first is a sort of just a cost budget question. So if the vendor is providing the software, is that a CapEx expense? And if so, can that be separated out from the rest of the budget? Because just to get a sense of what the operational costs might be ongoing once we purchase the software. And again, that doesn't have to be provided right now, but just a sense of what that looks like. If it's not a CapEx, then this is all operational costs. Then my question would be, what would be the cost for the ongoing cost to continue operating the software?
Right, so we have this projected for the
Sorry, I
next
didn't
3
finish my
years, the
question.
cost that you see on the summary.
Susan,
and
I
there
didn't
is-
finish my question,
Oh, sorry.
but now I lost my train of thought. So go ahead, please. Thank you.
Well, the summary, the costs that are on the summary sheet can be broken down into the initial application software and then an annual maintenance. So the annual maintenance is there listing as 65,015, and that's each year. In addition, there's the hosting cost, which is again over those 3 years. Services hours that's incorporated in there. So the initial implementation of the software is the 291,140.
And there's again, is that a cap? Is that a expensable cost, or is that a CapEx? Is that I mean,
I'm going to refer to Troy, or I'll get that answer. I know it's Troy. I'm not sure if you know specifics, but I can certainly get that for you.
We can get that for you, Commissioner.
I'm just, I mean, I'm glad this is happening, and glad to hear that we're going to have software that's now going to be fully integrated. Just want to make sure that what we're implementing is something that we're going to be able to maintain over time. Then my second question would be if there is a possibility of getting an implementation timeline, so we get a sense of when this is going to be all done. Is it within the 3 years of the contract, or is it the first year and then we get to see the results of it, beginning the second and third year? Anyway, you don't have to answer now, but please go ahead.
I have that answer.
Follow up. Yeah. Okay, great.
Yeah, we have that answer. So our projected implementation timeline is 9 to 12 months. 9 months is optimistic again because of, and we factored in a few extra months because of COVID and the uncertainty with all the COVID and different things that are happening in our organization. So we padded it for more by adding 3 to 4 additional months. Our goal is to have it fully up and running at all 3 sites by the end of this time next year, so that we certainly can see what that looks like, not only in year 1 as we get it up and running, but the next 2 years, which is part of this initial contract.
Thank you.
Okay, so I'm glad that you're actually presenting because, and I appreciate the very extensive answers you have given. I'm assuming these answers have also gone to the commission, Mark?
I'm sorry. No, I haven't sent them all to the commissioners. I usually just do it to the committee members, Commissioner, but I'm happy to forward them before the
I,
meeting.
I think particularly the one of the RL Datex is very pertinent because I think that Susan gave a very good explanation. It's one that I wish the whole commissioner would read, but the commission, but in fact, the written responses I thought were very appropriate so that they would see how exciting this is.
I will forward that information.
Okay, and in her presentation, she also obviously she's anticipated a number of other questions I had, and she answered them all very well because my initial question would have been, who are the entities, and because it reads as a system at Zuckerberg. And it's wonderful to hear that, in fact, we're all going to be using the same program and that it does extend to the primary clinics. And it'd be exciting if it also gets jail. I don't know, mental health has something in terms of its need, but it sounds like this is really a step up. I was going to ask, though, because Ms. Brajkovic does all of our root analysis and does it so well in her presentations. How is this going to enhance all you're doing? Do you need more people or do we use less? And are we going to have, you already had very high quality. So this is not a lot of money. So I'm just very interested in how we're going to improve over what has already been a very exemplary root cause analysis system that you put in.
Well, thank you, Dr. Chow. Appreciate the compliments and all. The short answer is it can only get better. And I say that because we can track and trend in a more meaningful way. So rather than individual incidents that are occurring, we can see the projections over time. We can share countermeasures between ourselves and Laguna Honda. So if we've instituted perhaps countermeasures for a fall here, perhaps they're the very same countermeasures that could be used at another institution within our system. And so it doesn't take more people. Once we get everyone up and trained, the user functionality and the easy to use is one of the reasons that this system really, in my opinion, having really played with all the systems in my 25 years, it excels because of the ease to use for not only the front end user who is putting the incident in, but for the back end users. And it really engages all folks beyond quality management, like unit-based managers, to run their own reports as well. So at any given time, once they're trained, they can be able to run and look at their own trends. And that is really the direction we need to go in when it comes to evaluating patient safety. It's not just a department that evaluates it, it's everyone's responsibility to evaluate and keep track of the patient safety events on their units. So it really is the creme de la creme in the technology space when it comes to the functionality for the users. And if you're impressed by what we do now manually, again, I can assure you, you're going to get a much better end product and larger reports that you can see how we're doing globally in the future.
Thank you. Commissioner Guillermo, I thought that as chair of Laguna Honda, you see, now we know that it's going to extend over to there. Are you excited?
Right. And actually, my last comment was going to be, the summary does not, as you mentioned, Dr. Chow, does not include any entities outside of ZSFG. And I was wondering if in the minutes you can reflect that the presentation included a description of the extension of this program to entities within the network. And not just Zuckerberg, because we'd really like to make sure that folks know that we're going to get this really great this great system that's going to be fully integrated, and as Dr. Chow said, stepping up even greater in terms of what we've already. I have to just say, this is just an editorial comment. What I have seen at Laguna Honda in terms of the particularly root cause analysis reports that we get over the last year and a half, they've been excellent in terms of how they've been presented and what they capture. And so I can't imagine, greater report than what we're getting, but I sure will welcome it. Yeah.
Thank you, Commissioner. And we certainly, I'll send to Mark the summary of what I provided, which does include the application to not only Laguna Honda and our facility, but to our primary care sites as well. They are included in this. And lastly, that upon approval, our goal is to bring this to the executive teams at all locations to share with them our excitement. I've been waiting to present this present for a long time. So we get the approval and the road show begins, because I've been waiting since I started here for this kind of technology.
Yeah, and I think that's why I had the question about ongoing operational costs, making sure that we're going to be able to accommodate whatever that level of expense or cost is going to be. So anticipating that this is going to end up being all that you promise, hopefully more. Yeah.
Commissioners, if I may, I just really want to thank Susan for her leadership. And I think I can't say enough about when she was interviewed for this position in 2015. This was something we talked about, having, this integrated incident reporting system. And I think this is a really exciting day for the Health Network. You mentioned, Commissioner Guillermo, around RCAs and Laguna Honda, ZSFG. This is all around centralization of our quality processes. And, this system is really going to advance us in so many ways when it comes to quality. And just to say, RL DataX is widely known as the best practice in this realm. And so we're very lucky to have this system at our, in our hands, and will absolutely continue to help us as we centralize all of our quality processes throughout the network. And then just one other quick thing around that piece, phase one is really what Susan said, primary care, ZSFG, Laguna Honda. Phase two, once we get some experience in this system and see how it works and see how it will help us, then we can start looking at areas like behavioral health and ambulatory care and such. So it's definitely part of the plan, and it is an exciting day, I have to say.
So Troy, we're both Commissioner Guillermo and I are very acquainted with the use of RCAs in hospitals.
Yeah.
And I'm not sure we've done as well in primary care, but I haven't sat in on those. How would you, is that a fair assessment that this will really move primary care, into a true RCA, or maybe you're already doing that for primary care?
Well, yeah, that's a great question, Commissioner. In primary care in particular, they have always been supported by our risk management team at ZSFG. So think about primary care, our risk management team is their risk management team. So we have done RCAs in the past in primary care. I think they're not as frequent as what you've seen, at the acute care hospital and at Laguna Honda. But if there is a need for an RCA in primary care, our risk management department, led by Susan, would oversee that.
And I want to share,
Oh, go ahead, Susan.
Commissioner Chow. So primary care isn't typically an area where we see a lot of risk, and that is industry-wide. But what we do see at primary care is a higher incident of complaints and grievances. And I know that independently, each of those clinics really have been doing a good job on their own to support complaints and grievances. However, Dr. Pachi and other physicians within primary care have consulted with risk management to assist them, because we are seeing more and more complaints and grievances coming not only from patients, but from Anthem Blue Cross and the insurers and different parties, such that there is a responsibility and a regulatory requirement to respond to those. So that is where I believe the module of the feedback, which captures that, will be more beneficial to primary care, maybe more so than incidents. But now that if we have a system that is easy to use, we may see more incidents that otherwise we didn't have from those primary care clinics.
Yeah.
Very, very good. I think the last question is mostly one of UCSF is using it. What other institutions are using it that you would like to quote from a reference standpoint?
Well, I know there are 3,500, not only in the nation, Canada, and the world. So I'm going to defer to our vendors, either Dave or Adam, to jump in and throw out a couple large systems that are using RL Datix. I know several, but I'll let you all share that.
And I've unmuted you so y'all can talk.
Thank you so much. It's Dave Swanson with RL Datix, and pleasure to be on the phone and meet everybody today. Yeah, clients of all sizes, from small community hospitals to organizations like the entire University of California campuses. All the campuses use our systems. Adventist, Sharp Healthcare, just to name a few of the California-based ones, but we do scale all the way up to the entire country of Denmark that uses our system, even for public entry of events and patient relations issues. So wealth, and 80 of the top, 90 of the top 100 hospitals, 10 of the 10 top hospitals, according to US News and Honor Roll. More importantly, we communicate and connect you with these organizations around the world. We have over 5,000 clients now globally, and we do want to make and provide a platform so that you can talk to other clients, bounce ideas off, get good feedback from questions that you might have, but also listen to you and develop our tools in reflection of your goals to provide safer environments for your employees, reduce your employee events, reduce your claims, safer environments for your staff, patients, and of course, just a safe organization altogether.
Well,
Hope that helps.
yes, Mr. Swanson, thank you. That's a very impressive set of references. So I appreciate that. Commissioner, I think that after all this, we should have a formal motion, whether to recommend or not to the Health Commission for acceptance, and help Susan get her Christmas present.
Thank you. Thank you, Early.
In that case, I'm happy to make the motion to accept the contract for RL Datix.
Okay, and these are one of the new contracts I'm really excited about, so I will second it.
That's great. Thank you, everyone. And I have a quick question. Are the jails going to be part of the network's use of this system? I know
Not in phase one, Mark. So right now it is Laguna Honda Hospital, Zuckerberg, San Francisco, and primary care for phase one. And we certainly can reevaluate after our first year. And along as with Troy at the network level, we can be discussing it with other opportunities within the network, but not in this phase, first phase.
Great. I sometimes jail are like the stepchild of things, and I know that they might have issues, but I'm glad that that's on the radar.
Now, the
They're part of the planning.
BHC is an area that will be included because currently we are risk management at Zuckerberg is overseeing the BHC. So the BHC is included in the overall ZSFG part.
Thank you so much, everyone. Item 6 is a request for approval for a new contract with the Regents of the University of California, San Francisco, and Nicole Trainer will be presenting.
Hello, how are you? Sorry, my camera just went out.
Nicole, I'm not sure if you've got both a phone and a computer on, but you're reverberating. We're hearing you twice, like a second after each other.
Sorry, is this better?
Yes, thank you. I'm sorry.
And I got my camera on. Good afternoon, everyone. My name is Nicole Trainer. I am the CHEP System of Care Contract Manager. I would also like to introduce the program lead at UCSF, which is Dr. Hannah Park. She's the Director of Population Health. I will be presenting on this new UCF contract, which was awarded via our CDC Disparities Grant, which is a national initiative to address COVID-19, public health disparities among populations at high risk and underserved communities. SFDPH, along with UCSF, jointly applied for this grant back in April of 2021. This particular contract with UCSF will be providing program evaluation and technical assistance to support and strengthen the infrastructure, which links San Francisco communities, the Public Health Department, the University of San Francisco, specifically the Department of Medicine, and other clinical networks to ensure timely responses to crises of COVID-19 during this pandemic. We have a specific focus on our priority population, which includes those who are most vulnerable in our communities as Black and Latinx communities, people who are experiencing homelessness, transgender communities, and also Asian American communities. Under this particular CDC grant, there are 3 primary strategies that we will be focusing on, which include expanding existing prevention resources and services to reduce COVID-19, increase and improve data collection and reporting, specifically among our priority populations, also build, leverage, and expand the infrastructure for COVID-19 for prevention and control. We also have some detailed activities under our work plan, and Dr. Hannah Park can also provide additional information for programmatic activities as well. The contract term is from June 2021 through May of 2023. The budget total is approximately $1.4 million. And so, and that's the overview of the contract with UCSF.
Thank you. Mark, are there any public comments?
There's nobody on the line, Commissioner.
Okay, good. Commissioner Guillermo?
I don't have any questions, just a comment that I'm really glad that we are going to be doing this evaluation. I feel the more data that we're able to gather and feed into the goals that we have around health equity, particularly given the Office of Health Equity's I think ambitious programs, that this can only help with what we're trying to achieve. And I'm really glad to hear that we're actually putting effort behind this, and that we did get the CDC grant, right? Yeah.
Yes, we did. Yes, we did. Thank you.
Okay, and I had my questions answered that this seems to be nicely integrated with our equity programs, which we really appreciate, and therefore that gives them more resources to
Absolutely.
be able to do our work. So if there was no public to publicly comment, then a motion is in order to recommend this to the commission.
I move approval of the new contract with UCSF.
Okay, and I will second that, and I think that actually will move that contract, and we're at the next item.
Yes, thank you, Ms. Trainer. Item 7, emerging issues.
So do we hear any, do we have any emerging issues for the committee here at the moment? And I don't see any, so let's move on to the next item.
Item 8 is public comment, and the only person on the line is one of the presenters, so I know that there's not public comment. So it leaves us with a consideration for adjournment.
Okay, consideration of adjournment is in order.
So I move that we adjourn the program committee meeting.
Like, I know we've got a few more hours to go to, so at our next meeting, but I will second that so that we can all get some rest and be prepared for the Health Commission meeting at 4 o'clock. Thank you very much, everybody, and we appreciate the responses that we have gotten also. Thank you.